And we were counting to make sure we had a quorum, and we do. Thank you, everyone, for showing up today. Appreciate that. We've got a lot of things to go over today. I'll call the meeting into order. Ms. Corbin, if you would, please call the roll.
Preble Acton. Rhonda Allen. Dr. Andrea Anthony. Here. Doug Bodery. Amber Brown. Here. Shay Crowell. Holly Deering. Here. Mary Hickerson. Here. Lois Miller. Alan McAdoo. Jeff Phillips. Here. Shantae Sherrill. Here. Eric Tutobeni.
I made it. Eric made it.
It's a quorum.
Well, we have a quorum. Thank you, Ms. Corbin. Members, next on the agenda is to approve the minutes from our last meeting. I'll entertain a motion to accept. Is there a motion?
Motion to approve.
A motion to approve the minutes. Is there a second? And a second. Any further discussion? Seeing none. Madam Clerk, please call the roll.
Preble Acton. Dr. Andrea Anthony.
Yes.
Amber Brown.
Yes.
Holly Deering.
Yes.
Mary Hickerson.
Yes.
Jeff Phillips.
Yes.
Shantae Sherrill.
Yes.
Eric Tutobeni.
Yes.
Mayor.
Our motion passes. Next members on our agenda is our financials. Mr. Elam, you're recognized.
Yes, sir. All right, for the, I have 2 months here. For the month of June of 2021, you will see that the revenue was $7,876,949. Expenditures, $10,176,181, for a negative difference of $2,299,232. And for the month, for the totals we have for the January through June, we have $49,263,478 in revenue. Expenditures, $43,746,496. And you have a positive total of $5,516,981. Total enrollment, 6,303. And on the 2020-2021 fiscal year totals that actually finished up the year, you have $84,595,064 in revenue. Expenditures, $87,528,829, with a negative balance of $2,933,765. That's for the month of June. For the month of July, your fiscal year for July total in the month will be the same. Year to date will be the same. But starting at the top for your 2021 calendar year, you will see there was revenue of $1,822,293. Expenses, $6,390,487. Revenue less expenditures, you'll see that it's a negative $4,568,194. The total For the year-to-date, $51,085,771 in revenue. In expenditures, $50,136,983. And then revenue less expenditures, there's a positive $948,778. And your enrollment, total enrollment for the month of July 2021 was 6,302. And again, as I told you, the year-to-date for the fiscal year and for July 21 is the same. Moving to the 266 fund for the month of June, you will see that workers' comp, $23,980.89. OJI, $36,765.38. And for the total is $60,746.27. On the year-to-date total, you will see $154,628.40 for workers' comp. For OJI, you see the total is $512,851.31. Total claims is $667,479.71. For the month of July, on the next page, and the year-to-dates will be the same. Workers' comp, $2,221.82. OJI, $77,634.38. And you see a total of $79,856.20. Mr. Chairman, that concludes my report.
Thank you, Mr. Elam. Any questions for Mr. Elam on this financial report? Seeing none, Madam Clerk, if you would please call the roll. All right, I need a motion. I need a motion to accept the report. Got a motion. Is there a second? And second. Please call the roll, Madam Clerk.
Mary Hickerson.
Yes.
Jeff Phillips.
Yes.
Shantae Sherrill.
Yes.
Eric Tito-Benning.
Yes.
Mayor.
Thank you. Motion passes. Next, we have the work comp OJI report. Mr. Good. Recognize Dan. Thank you, sir.
I'd like to report in the month of July that we had a total of 4 injuries requiring medical attention. I'd also like to bring to your attention that in the period of time that I've been with the county is the least number of medical injuries we've had in a given month in the time that I've been here.
So what are you doing?
14 years.
Oh, what are you doing to make it better?
Oh, what are we doing? We've got a number of things going on, sir. We are partnering with the Board of Education Maintenance Department and with our own county maintenance department to follow up on inspections and to improve the relationship within the school and the county departments. We're also working to follow up with some of the inspections, getting on hands-on with some of the custodians and training and things like that. And we've also improved and upgraded our safety to the schools and the county.
Well, I say congratulations. That's a good report.
So 4 is the best we've had in the time that I've been here. The interesting thing, the second most one visit was 5, and that was done last year in April when the county was basically shut down for a an entire month, and the Board of Education was doing virtual training, and the county was working from home. So this 4 is significant in the fact that we had the whole county still working, and we got down to that. So I just wanted to bring that to your attention. And I applaud, not myself, but all the county employees, because they're the ones to make that happen. That brings the total to for the year to 93. Of those 93, 65 are OSHA recordable. 28 had restricted days, 16 year-to-date have lost time days, and 21 all others. The next page of your report, you'll see that the total this year is compared to the same time last year. We had 93 this year, 82 last year at this time, and 185 3 years ago. The incurred dollars year-to-date is $377,000. And last month, because we only had 4 injuries, the incurred dollars for the month was $12,000. I just like to always caution you those incurred dollars are an estimate on what it's going to take to close those claims, and as they go through the period of getting treatment and things, those dollars are adjusted. Of the 4 injuries, 2 of them were with the Board of Education, and 2 of them were with the County General. And within the County General, 1 was with the Sheriff's Department, and 1 with the EMS. And that completes my report, sir.
All right. That's your best report in 14 years, right? Thank you, Commissioner Phillips. Is there a second? And a second. Any further discussion? Seeing none, all those in favor signify by saying aye. Aye. All opposed, motion carries. Thank you, Mr. Goodwin. Absolutely. Next, we'll move to the wellness update. Mr. Elam.
Yes, first let me say Rutherford County, our risk management department, received the news that Mr. Chuck Chapa is taking another job and is actually moving out of state. So we wish him well. He's done a fabulous job for Rutherford County. He's really been instrumental in the partnership that we have with MedPoint and with Cigna in trying to really raise the level of wellness. I think if you compare Rutherford County to other counties as we have, when we look at our participation in my Cigna app and our motivation points here compared to other counties, and I think Mr. Hoffman will also tell you that we are way better than average in a lot of other counties, and Chuck was a big part of that and was very instrumental, and he will be missed. So, moving on to his report that I'm filling in for, starting with the annual physicals, you have 1,963 compared to 1,508 last year. Biometric screenings, you have 2,644 compared to 1,928 last year. Health assessments online, you have 1,081 compared to 461 last year. Mammograms, you have 892 compared to 829 last year. OBGYN screenings, you have 1,343 compared to 1,384 last year. Colon cancer screenings, you have 326 compared to 320 last year. Cervical cancer screenings, you have 1,342 compared to 1,176 last year. Prostate exam screenings, you have 473 compared to 351 last year. Flu shots, 2,027 compared to 876 2020. Work with a health coach to achieve a health goal, you have 9, and that was a new goal for this year. Chronic health, working with the health coach, is 8, and then complete 16 weeks of Omada diabetes prevention, there's 4. Looking at the very bottom, the total, the goals met, 3,489 compared to 2,491 last year. I do want to mention there's a mobile mammography bus that's going to be at the Board of Ed. and it is scheduled for August 24th. And we're also looking at October the 15th, so you can go online and you can schedule if there's any availability. Most time those fill up pretty quick. And that concludes my report, Mr. Chairman.
Okay, thank you very much for filling in. Mr. Elam, if you would, I think it'd be appropriate if you would pen a letter. I'd like to sign on to it as well on behalf of this committee. Thank Mr. Chapa for all of his years. I almost felt like he was one of our employees instead of Cigna, but just thanking him for his service, and we wish him the best, even though he's going to North Carolina. Sorry, we're losing a good Tennessean, but we'd like to wish him his best and tell him thanks for serving us and this committee and especially our members, county employees over the years. He was here when I got here, so he's been here for a time. So appreciate you getting that done for us, Ed. Next we have, yes, ma'am, Mary.
Do we have any information? I know I'm hoping we still have Miss Lee. Do we have a replacement? Are they replacing Chuck? What? And that may be covered later. Just tell me, I'll get it later.
No, just to fill you in, yes, we're in the process. I've had several conversations with Cigna, which was Chuck's boss, Susan, with Cigna, and they have already got it out there. They've already got it listed. And so I feel like, based on the speed that they're taking, they feel like that they're going to have some good applicants, and this should move along pretty quickly.
And they're foreseeing to have this person come in and fill in with y'all and us, just like Chuck did. There's no.
I have not been told anything different other than, he won't fill Chuck's shoes. I can promise you that.
Oh, absolutely.
But he'll have to grow his own. So.
Exactly. Thank you.
Or her. I don't want to be improper here. Him or her.
Good recovery. Next, we'll move to our MedPoint report. Ms. O'Neill. How are you today? Good. Doing well, thank you.
Good afternoon. So we'll go ahead and start out with our visit analysis. If you want to go to page 3 for the visit summary, you'll see that the health center saw 896 visits in July. 749 of those were unique members. New Salem saw 438, Stewart's Creek 269, and Walter Hill 189. It was one of our largest months to date for visits. We were glad to see that. On page 4, our visit summary by member type, we saw 121 children, 657 employees, and 118 spouses. Page 5 on the appointment type summary, so 126 members had more than one visit in the month of July. 2 members had 5 visits. 124 members had 2 to 3 visits. Of all the visits that we had 178 annual exams, 28 dietitian visits, 360 established patient visits, which could be anything from a med refill to an illness, 40 new patients, 188 nurse visits, the majority of those were biometric screenings, 16 telehealth phone visits, and 86 total virtual visits, which includes both the audio and video components. Page 6 on the visit summary by day. So July had 26 available scheduling days. There were 5 Thursdays, Fridays, and Saturdays in the month of July. Mondays and Wednesdays were the busiest day. And there were only 3 Mondays in the month of July because all the health centers were closed on Monday, July 5th for the holiday. Page 7 on in-person versus virtual appointments. We had 102 virtual appointments in the month of July. Stewart's Creek had the highest average virtual utilization. That's the first month that Stewart's Creek was the highest by itself. Generally, it's Walter Hill, so it's kind of nice to see that change up a little bit. Only about 9%, though, this month were virtual visits, so you can see more people are coming into the clinics. Of those visits, 61% were done ahead of time for people who just wanted med refills and choice and whatnot. Just over 39% decided to have a virtual visit based on symptoms. In-person versus virtual appointments continued. So total since opening the clinics, we have had 8,098 visits, and of those, 1,731 were virtual, which is just over 21% were virtual appointments since we've opened. In the month of July, just over 11.5% were virtual there in that total. We had 79 referrals in the month of July. 18 of those were to a dietitian, 15 to gastroenterology, 9 to behavioral health, 8 to dermatology, 5 to orthopedic and orthopedic surgery, 4 to vascular surgery, 4 to neurology, 3 to physical therapy, 2 to sleep medicine, and 2 to gynecology. 39 of those referrals came from New Salem, 27 from Stewart's Creek, and 13 from Walter Hill. In our financials on page 11, you'll see that we had 749 total unique members, a total operating cost of $173,457.04 for a PEPM of $27. In our population health analytics, you'll see that the general adult medical exam was our by far highest diagnosis code used at 41.17%. We love seeing that. We like to see them for screening so we can avoid illness. Coming in second was, again, a screening code, but this one was for diabetes, and that was at 6.17%. And then in third, we have our first actual problem-based diagnosis code at 5.61% for essential hypertension. We saw 69.98% of our members were female in the month of July that we saw, and the age range of 40 to 49 in both the female and male population were the highest seen. That being said, there is a good collection of multiple age groups in the month of July. You know, we saw 73 kids between 10 and 19, 64 of our members were between 20 and 29, 157 members were between 30 and 39, and 93 members were between 60 and 69 outside of that age range of the highest amount, which was 255 for the 40 to 49 age group and 219 in the 50 to 59 age group. So it was nice to see a good collection of all the ages coming through the clinics. On page 15 for our BMI summary, in July, the female members' highest percent of BMI is in the obese category, and in the male members' highest percent of BMI was in the overweight category. And then just a couple of announcements to go along with our report. Mandy Baxter, our behavioral health nurse practitioner, is now seeing patients. She is seeing them both virtually and at the New Salem Clinic in person. So that's available to the members now. And then we also have set up 3 biometric screening events in the month of September to help people have more access to get their points. And those will be on September 11th, September 18th, and September 25th, all at the New Salem location. Hopefully members will remember that they need to be fasting for us to be able to complete that biometric screening. However, if they did come in where they're not fasting, we can order their labs and they can have those drawn on another day, and we can complete the rest of the biometric screening beyond the labs. All right, and that concludes my report.
Thank you, Ms. O'Neill. Any questions for Ms. O'Neill on her report? Mary?
Maybe not on the report, but back to the bio screenings that you've got set up in September. Will there be more information, dates and times sent out to our employees?
Yeah, we're planning some communication to come out to the employees so that everyone will be aware of it. The plan right now is for that to last from 7 in the morning till noon, so that it's earlier in the day for those to be fasting. And it will be on those last 3 Saturdays of September.
Let me, before you leave, Amber, any other questions on the report? Okay. Let me, members, say one thing, and we'll have a little bit of discussion on this before you leave, Amber. You know, in the business world, when you have a partnership with somebody, the lack of communication is the first thing that will hurt or destroy a partnership. But then through communication is the best thing that can improve that partnership and make things better. And so my office, and the mayor's office, had received a few complaints from our employees and reached out to Beth Wilson, she's back here, and Miss Heather Jenkins, and they immediately, when I expressed some of the concerns we were getting from employees, they showed up yesterday. We sat down and met. We communicated. We have the commitment from St. Thomas Ascension to make improvements of better communication to our employees, especially at the at our location out on Salem. The problems that we were hearing coming into my office was that they were going to the Salem to get checked, and it's supposed to have signage for Rutherford County employees. Well, they said if they showed up, they might have a slight temperature, they might have sore throat or a cough. Well, they were being turned away and sent to the Kroger Little Clinic or wherever else. I had just a few in my own office that did the same thing. So it started making us wonder, well, why do we have a partnership if, you don't know if you have COVID, but that's why you're going to the walk-in clinic with this partnership to see what you do have. So I think we now realize the best way to handle that, and so, Amber, are you prepared to?
Yes, sir.
Tell us what transpired yesterday and how we're going to handle it, because there was no need to have a partnership if we're going to send everybody away and tell them to go to Kroger and get tested there. So if you will, just bring us up to date on where we are and making this improvement in our partnership even better.
Absolutely. So first off, just to know that we did improve the signage. We had signage at New Salem, but we have improved it because some members were showing up and they were actually checking in for the wrong clinic, and so there was some confusion there. So we have improved that signage so that there isn't any confusion, and they are going to us, because whereas we do have a walk-in clinic, the rest of the clinics there at New Salem do not. And so they were thinking that they were talking to one of their own patients saying, we don't have a walk-in anymore. We used to, we don't have it anymore, and then they were getting turned away. Well, they were at the wrong clinic. So I have added additional signage downstairs to help direct the members, whereas there was always a wall sign directing on the wall next to the elevator. If you didn't look there, you may not see that, or if you didn't know exactly where to look, you may not see that. So I added additional larger signage directing people to go upstairs to the correct check-in so that that won't happen anymore. And as far as, whether or not people are coming in sick or being turned away or whatnot, we are not turning away people who are sick. We are, however, trying to also reduce exposures for both the patient, other patients. We have a lot of kids who are now coming into the clinic. We don't want them exposed. We don't want teachers exposed. So what we're going to ask them to do is return to their car, but stay in our parking lot. And we're going to see them virtually from there. And then if they need to have any sort of testing done, whether that be flu, whether that be strep, whether that be COVID, as we have ordered COVID tests, and they will be coming in, and we will be able to screen for COVID as well, we can do that with them there, right there in the car. And we can swab them right from the window. And that way, they don't expose anyone else, we don't expose our staff, so we can keep serving you, and we don't expose the other patients who are in the clinics. Then if we find that they're negative and, hey, we need to listen to their lungs, or we need to do something else, we need to do an EKG, we can certainly ask them to come up into the clinic. But most of those things we can accomplish right there from their vehicle and still provide all the same services that we would have had they walked into the exam room.
Any questions? Lisa?
My question was on the other facilities. Is there a different protocol for those, Walter Hill and Sturge Creek?
So we can still provide those same services at Walter Hill and Stewart's Creek. We do want to make sure that we're exceptionally careful being on the school campuses with that, so that we're not intermingling with those kids who are outside playing, especially on the Stewart's Creek campus. They tend to play right outside the front door of the clinics and whatnot. So we just really are thinking through that process. It will, I believe, be very similar to New Salem, but we may just really want to look at that very in-depth just to make sure so that we're not exposing those children.
Mary?
Real quick question, if you've got a patient that has come up and has no means of doing the virtual in the car, is there something provided for them? Because I'm thinking my mother's a retired employee, so she's on it, and she goes to the clinic. She has a flip phone. So is there...
Certainly. So the first thing that we can do with that is, we, whenever possible, want it to be a full audio-video component. But we do have a few that we do just by telehealth. So we could call her on her flip phone. Okay. So it's not that we have to have that visual component to be able to provide service. Okay. If there is absolutely no audio or video or any sort of component we can provide for them, we will do the very best we can to serve them. And if that means that we have to bring them into an exam room that's isolated, we may need to do that. But we're really trying not to, just so that people are safe.
But you could do tele and not have...
Absolutely.
Okay, thank you.
Amber?
And I think this might have already been mentioned, but there will be a communication about this on, I guess, this new kind of policy of people having to wait in their car.
Yeah, we will communicate it to them, especially when they call in to schedule, or if they walk in, we're going to have a flyer for them to, hey, go out, call this number, here's why. We're going to try very hard to make sure that they have follow-up instructions that are in writing, so that if they do test positive, they have something to take home with them, even though they're still talking to the provider. We are going to do everything we can to make sure that everyone is taken care of and has all the communication they need.
Other questions? Seeing none. Thank you, Amber. Thank you all. Thank you, Beth. Thank you, Heather, for meeting with us yesterday and making such quick changes. And sometimes in this world, especially in these COVID days, just like the health department, we have to pivot. Sometimes the goalpost moves 2 or 3 times a day. And we're having to pivot for that just to adjust to what's coming our way. So thank you all with Ascension. And thank you for your report, Amber. Next we have, it's just a report. No, sir. I think we're good. Next we have item number 8, annual enrollment update. Ms. Griffey. Thank you, ladies.
Thank you, Mayor. Just a couple of quick updates to remind you that our annual enrollment will kick off on October 1st at noon, and it will go through October 29th at noon. This year we did extend it for a 4-week period for several reasons. There are a lot of changes that were made to the plans this next year, and also we have a new benefits enrollment system, so we extended the period. We rolled out our new benefits system to our county general population in the month of June, and pretty much most of those employees are registered for an account in preparation for annual enrollment. We kicked it off with our Board of Ed group a couple weeks ago. Out of about a little over 5,000, we're right at about 1,200 now. There's a little technical issues they're having this week with their emails, so we haven't been able to push more communications this week, but we plan as soon as we get the word to push some more communications, get that going again. We wanted to try to target the new system so we can get those registered and make sure that there are no issues getting an account registered, and we can devote our time when it comes to the actual annual enrollment period to assisting employees. Right now, we have communications that were just finalized this week. They will take approximately 7 to 14 days at the printer, and then they will go out they will be mailed to homes. That roughly will happen around the 7th of September, provided there are no issues at the printer. We also, once those go out, we will be able to send a PDF copy of the guide out if it's requested by employees, and we will start fielding appointments for employees that need assistance and need help deciding on what plan they need due to all the changes that were made. I think we brought this up last meeting that we did put in a appointment scheduler online. We will be rolling that out as part of our communication to employees also, where they can go online and make an appointment with a benefit specialist to get some questions answered. We have other various educational pieces that we're putting together, and those will be going out in the month of September also. And that's it.
Any questions for Ms. Griffey? Seeing none. Thank you, Melissa. Next, member, Ed? The wellness fair. I'm sorry. I didn't mean to skip over that. It'll be short anyway. Go ahead, Ed.
Trying to look at our to have the exposure and have people out in the departments. Oh, I wish y'all stopped me earlier. I don't know if I can repeat it all, but anyway, the Wellness Fair for October the 15th has been canceled, and the...
You blame me for canceling that, so go ahead.
Well, no, we had a discussion in trying to discuss our employees and the exposure, the concern about the exposure.
That's true.
Mayor Ketcher and I talked about it, and he decided that would probably be best for our department. With the Wellness Fair being in the middle of the month, if we had exposures and then it wiped out our benefit specialists, it would just be very difficult to recover from that the last 2 weeks, because I think everybody knows people wait till the last minute on a lot of stuff, and then we would be down a lot of specialists. So we have gone to the scheduling. We're encouraging emails because we can answer those beyond our office hours and try to give the employees the answers that they need in order to make good decisions.
That was because Ed and his staff at the department, they just do such a great job, but they're also limited in staff, and we can't afford to have, even during this enrollment, because it is a little more in depth than what it has been in the past, and we can't afford for anybody to be down during that period of time. So we wanted to limit that exposure for our employees as well as our department and employees as well. So any questions on that? Not, then we'll move to item number 9. Mr. John Moffitt is in the audience with us today. John has been a friend of mine for many, many years. He's sitting in the back. His family has owned Ryan Florist for over 50 years right down the street, and he's kind of retired. But he's introduced me to these gentlemen here with Knox Health. Would like to make a presentation. You'll find that on your SharePoint tablet in front of you. And so at this point in time, I'd like to call on the 2 gentlemen from Knox Health to come up and talk to us about sleep charge and how they think that it could actually save us money on our health insurance. Gentlemen, if you'll introduce yourself and you're recognized.
Sure. I think I'll work off the laptop. So I want to talk sleep? for a little bit. Your circadian rhythm drops this time of the day, so we'll do our best to keep you awake. This will take a little bit longer than some of the other agenda items. My name is Larry Barrett. I'm with Knox Health. I oversee our business in the eastern half of the U.S. To give you a little background on Knox Health, we're a global sleep healthcare provider. We are Atlanta-based, and we also have a division in Iceland. That is our Knox Medical division. They are more device-based, diagnostic, and a lot of research. What we'll talk about today on the Knox Health side, our product Sleep Charge, is we are sleep healthcare providers. And this will cover our employer-based program. I think one thing that's important to keep in mind is we are a healthcare provider. So as we go through this, and you think of particularly the wellness folks as your point solutions and things like that, frame us up as a sleep healthcare provider, specializing in sleep. Please ask questions as we go. John, this is John Letter. He's our COO and president.
Yeah, thank you for your time.
Yep, came up from Atlanta. I'm Richmond-based, so I took a 9-hour jaunt and got tired at the end, but I made it. And tonight I'll stop halfway on the way home. So John will take you through a little bit on company history. We'll shift back and forth a little bit, try not to too much.
Sure. Thank you, Larry, and thank you all for your time. Just to give you a little bit of an understanding about our background, our experience, where we came from. We like to say that we were telehealth before there was telehealth. So we started actually through a research study to determine if we could test and treat truck drivers remotely for sleep apnea when they're in California and they're not getting home for 3 weeks and they're off the road. So that was sort of where we came from. So we built an entire model to take someone through an assessment or a risk factor all the way through testing, treating, and if diagnosed with sleep apnea, putting them onto therapy right there so they can get back on the road. That has evolved over time, particularly from customer feedback as we've grown, and we've now added more services, sleep services that we handle. Things like insomnia treatments and treatments for restlessness and circadian rhythm disorders. So we've really expanded. We've always been research-based. We are part of the largest ever funded sleep study with the NIH and the University of Michigan, where right now we are doing a research study on post-acute care for those that suffered strokes. And by treating them immediately for their sleep apnea with PAP therapy, which is positive airway pressure, can they stop or lower readmissions or more strokes? So always been based in research, and our business model has primarily been in serving Fortune 500 employers, companies like Coca-Cola or Delta Airlines. A lot of obvious reasons, a lot of things that were talked about today, things like workers' comp injuries, things like on-the-job injuries, things like taking part in an on-site, near-site clinic strategy. 2 of those claims I heard last month were for sleep medicine. But the important thing to understand about us is we're really about starting a conversation with someone about their health through their sleep. And not only solving their sleep issue, but solving their health issue through healthy sleep. So there's a lot of coordination that we do as an organization. Am I going to take them through a little bit more? Okay. So don't listen to us, listen to CDC. It's a big problem and a growing problem. There are over 70 million Americans that have issues sleeping. It's estimated that 45 to 50% of any one of us has an issue sleeping each night. So as you could imagine, you're more likely to have an injury. You're more likely to have a disability claim that's extended. You're more likely to take leave, all of these good things or these things that happen in business each and every day that cost a lot of money. So we work to prevent those things. The reason it's happening is, and we're careful with this, understanding that we deal with healthcare and we are a healthcare provider. But the reality is that the way the healthcare system for sleep is built is that people ping pong around. they're self-directing their care. They're largely getting to a primary care physician through tons of frustration that sends them to a sleep specialist, that sends them to a sleep lab, or denies a lab claim, and they take a home sleep test, and then they go back to the physician. Then they go to a durable medical equipment provider if they need treatment. And then after 90 days, they're on their own. And people are left to solve their sleep health issues on their own. And the reality is that they fail. They fail dramatically. So if you can imagine, as you're managing a budget, and you're talking about it each and every day like I do, you're thinking about how do we make sure that our cost is effective, right? That what we're doing is actually paying off for people. The reality is, in the healthcare system for sleep health right now, of 100 people, 15 to 20 of them are ever getting diagnosed. And statistically, it's after 10 years. So 10 years of contributing to or causing chronic disease that's associated with poor sleep is happening. And it's only taken care of, or at least addressed, when people are at their frustration point. So even the people that get to the care, the 15% that get to care and are diagnosed, start their therapy. And of those that start their therapy, half of them quit in the first year. So if you think about the healthcare system and the cost that goes into that, the waste that goes into paying for people that aren't treated properly, that's sort of what we work to fix. And we put this in here to just make the point. These are 3 common chronic, as we call them, sleep-related conditions that are directly related to poor sleep. Diabetes, high cholesterol, and in this case, hypertension. And what you see are the prevalence rates of those with diabetes that also have a co-occurring sleep problem, sleep apnea in this case. So 72% of diabetics are estimated to have treatable sleep apnea. The reality is that most of them have no idea. But when you look at the claims cost, which we do as part of what we do each and every year, there is a huge accelerant to those people. So when you look at your average health plan member costing you $6,000, $7,000 a year to insure, if they've got diabetes, they're now costing you $16,000 a year. If they also have co-occurring sleep apnea, they're now costing you $25,000 a year. So it's a cost accelerant. Not only is it a workers' comp or an injury or productivity, it's a huge cost drag on the healthcare system. You want to take over?
Yeah.
Thank you.
I'll solve your problem. Everybody's on slide 7, correct? Following along okay? So the solution, how do we solve what John talked about? Integrated sleep medicine program. And if you go to the next slide, this is similar to what John laid out. These problems, these align with the first 3 John talked about. We've made it accessible. So back from 11 years ago, John mentioned the apnea. We'd go to the patient. So at the time, it was very early. It was telephonic, but it was still remote. Our whole model was built outside of brick and mortar where we go to the patient. So we were virtual early. The good news about that is in the last 18 months, we didn't have a significant shift to make. That's how we built this. Granted, Amber, to your point, we had to add telehealth interface, but the model itself we adapted pretty well, pretty quickly. So accessibility, comprehensive, we can scale. Because of that model I just talked about, I mean, we can go throughout the U.S. Now, I know that wouldn't apply to you all, but some of our larger companies, regardless of location or role, work location or where they reside, we've got them covered. So that allows us to treat virtually and comprehensively in our approach. And then outcomes focus, the most important thing for us is to improve the patient's total health through sleep. We work with the patient. For the employer, we're able to aggregate that patient data and report back to them, whether it's incident, accident, comorbid conditions, health plan costs, so that patient success gets rolled and aggregated so we can report it back to the employer. So John showed this earlier, the 15 to 20% undiagnosed. When you look at our book of business, which would be our patient population, and in this case, employees that are now patients, that original number of 15 to 25%, only those diagnosed, we capture 79% of that. So we do an early risk identification. People learn about their duration, time, and quality, learn a little bit about sleep. Those at risk, we'll talk to our physicians and move through the process. And so we're getting 79% of those folks that on the first slide, we're only capturing 15 to 20. So that's a really good starting point for what we're trying to accomplish. Secondly, the number increases there. 81% of those start treatment after diagnosis. So a lot of those obstacles that are removed, brick and mortar lab testing, that fragmented system, go get my DME, go back to my PCP, it streamlines it all into a full episode of care for that patient. So it really simplifies it. And then after 1 year, you saw the fall off. By the time you whittle down that group, those being tested, or those being diagnosed, those being tested, those that fall off, we have 87% retention rate. Now in transportation, that's a lot higher, because that's less about compliance and more about, or it is more about compliance and adherence, because they have to. So when you get in the CDL world, it changes that dynamic, but 87% versus an industry standard of anywhere from 40 to 60 compliance, I'm pretty proud of that, and that's what gets us where we are. So slide 10, this goes back. John showed you the impact of sleep on other chronic conditions as an accelerant. This is our book of business, and what this does is it adds in that blue bar. Okay, and looks at the cost of sleep charge participants versus that cohort baseline that John mentioned. As you can see, we've brought that, like using diabetes as an example, we've brought that $22,000 and some change, reduced that cost down to a $16,000. So what we see year 1, year 2, and ongoing, that total PMPY for the company, but more important, the patient, healthcare spending starts to come down. And we see this throughout. These are 3 examples. The one thing, and I'll show you on another slide, we can do this in aggregate. We can look at the total organization, medical spend, and then you start to drill down to these sleep-related conditions, as we call them. So you might have an initiative that said, look, Larry, diabetes is really number 1 for us. Well, we know the bidirectional and root cause relationship there. So let's look at the patients with diabetes, and let's track them and see what impact we're having on your current diabetes program. Questions? Please ask. Okay. So how does it work? We've covered a lot of this. The first bullet point, I mean, these are our goals. Number 1, we're improving lives. From an employer standpoint and the individual, we're lowering healthcare costs. We do this, you hear a lot about digital technology. We are human support. It's a very personal approach we take, and it's enabled by technology. So we kind of flip that paradigm. That's our model, our platform that allows us to do what we do. But ultimately, it's one-on-one with the patient, and we manage them from the first time they take an evaluation through diagnosis and throughout care. Okay? Medical team. So as a healthcare provider, this is what's so important to us. We interact with the person on a whole person level. So sleep is a fundamental building block to that, and we look at that person's total health through sleep. For that reason, our clinical and our medical team have to represent that. So when you look down under Dr. Barrett heads up he's our medical director over our sleep medicine team. If you see on the right, Dr. Ong, behavioral sleep medicine. Why is that? Number 1, adapting to apnea for 1, insomnia, the bidirectional relationship with mental health. It's extremely important that we're aware and that we recognize the interrelated nature of those 2 conditions. So when someone comes to us, we need these multidisciplinary backgrounds to manage total person and certainly sleep. Any questions there? I'm going to jump ahead to slide 15, and then we'll go back to 14 real quick. So the question from a benefits person, Larry, this is great. How does an employee get started? How do they get moving through this program? I've listed some. I'm not going to go through them at all. One thing I do want to point here, MedPoint. So when we have an on-site clinic situation and we work with Premise and a couple of accounts, what that really does is it solves some of that complexity in the system. Now we have a primary care physician. We have an employee, and I heard it mentioned earlier, going on a wellness visit. Sleep becomes a part of that conversation. So I go in, diabetes concerns, I'm snoring a little bit, got some anxiety during the pandemic. Doc, can you help? In the current system, that doesn't always get to a sleep specialist. That PCP is swamped. And where do you send them? Do you have a provider that says, I want you to go see the specialist? And you go in and say, Doc, I'm having trouble sleeping. Doesn't happen. So in the clinic environment, it creates a control and a quality that allows your clinicians, being aware of the program, to really work with us and collaborate. and manage that total person care. You'll see some others on there. The checkup you see on the right is a digital interface. An employee can go straight into that and start their checkup process. The other thing I'll mention, we talked about workers' comp and on-the-job injury. There are situations where fatigue suspicion and other issues, on-the-job training, errors, defects, accidents, where a manager might refer somebody, or they may say, look, I'm tired. I've been snoring, I'm worn out, that's why I'm making mistakes. So that could be a referral. So lots of ways to enter. I just wanted to list those there. This can be a long discussion. I'll try to make it quick. So the person's entered the program regardless of how they entered. There's a lot of education and awareness for everyone, the full population, because we all sleep, we all need help, short-term, long-term. What that initial consultation looks like with the physician is what I said a minute ago. I'm Larry, I came to you, I'm having sleep issues. They've got intake, just like a physician would. They know the medical history. Let's talk about your sleep. That quickly moves, if suspicion is of a sleep disorder, we're there to address the root cause, first of all. If we've got an apnea, high-risk apnea, we're doing remote testing. It's a very efficient process. Testing comes back to us, diagnosis, DME, starting care, ongoing care. I'm talking apnea from beginning to end. From that first time they do their checkup to ongoing care if diagnosed, it's all done through one source. Full episode of care, managing that process. I may have an issue with insomnia, I may also have apnea. I may have some anxiety. That's what that physician consultation is about. Learning about Larry's total person and how sleep may be impacting that. I mentioned testing and diagnosis. In apnea, you're going to see it as testing and diagnosis. I may not be at risk for apnea, but I've got insomnia. Different situation. That gets into behavioral sleep medicine. So we have solutions for insomnia. There's often co-occurring. So we're managing all of sleep. Therapy and treatment, I've mentioned some of this, but as you go through this process, one thing that's really important, the digital monitoring. Our technology, our cloud platform provides ongoing data. I'm a patient on our platform. At 10 o'clock this morning, our care team in Atlanta saw my results from last night, sleeping. They can act on it. They see Larry over time. They see Larry not using his equipment. They see my mask leaking. Larry's got a problem. I need to call him. Apnea treatment today doesn't happen. So we've got a very proactive outreach team. I may have insomnia that's developed. They can't see that on my PAP, but I'm calling them saying I need some help. So it never stops, that one-on-one interaction. And then continuous care, I mentioned that. That's the full episode. Any questions on this? I know I went through it pretty quickly. And John, you want to cover the ROI? Pick up on 17?
Forgive me, as I was watching you, I realized that you all weren't connected to this, and you're bouncing around your presentation separately. So forgive me, I'll try and direct you to the slides. We're on slide 17. And it's about outcomes, so that you understand people that are in our program. Statistically, U.S. adults sleep about 6 hours or slightly less now. It's dramatic. It's an epidemic of sleeplessness in America. Folks that are in our program are sleeping 6.8 hours, or 6.7 hours, and they're using their therapy every day. The Medicare, Medicaid standards for what is considered to be compliant to therapy for apnea is 4 hours a night, 70% of the time. And physiologically, you need to sleep at least 6 hours a night. So it's important that we're sharing, that we're helping people get the appropriate levels of sleep each and every night. We use quality of life measurements like the SF-36 and the SF-12 to determine outcomes for people related to their quality of life, and more vitality, 34% more vitality in our most recent SF-12 that we presented. But overall health, mental health, behavioral health. Satisfaction is very important to us. We started with a patient satisfaction survey that asked us how we did. It was 92% rated us as above average or excellent care. We've most recently this year kicked off a Net Promoter Score, an NPS score, and our most recent NPS rating is 75. So if you can imagine in healthcare, 16 to 27 is sort of the measurement of good. And for those of you that know NPS, anything positive is good. So we're very pleased there. But what's most important to us is those detractors and what are they saying about us and how can we be better. And then on the right, as we talked about earlier, is really how do we impact people's lives, but how do we impact the bottom line? We know that we're 3.6 times better than the current system at keeping people in therapy because most sleep disorders are chronic in nature, so they take continuous management. We've also shown in several clients a significant per member per year savings for people that are in our program, and that relates to waste in the system because we don't have a fee-for-service model. We have a value-based model, which is very different. So we eliminate a lot of waste for someone that's tested that doesn't get to treatment. So we're only paid when someone actually agrees to a therapy for us. So we're able to pull waste out of the system, and we're able to show on average claims cost for people each year, and we would show that for the county as well, each and every year, of about $1,570 in avoided waste and claims cost. And then when you look at that group that we looked at earlier, the chronic condition group, and I'm not sure about the percentage of chronic conditions within the county population, but if they're significant, you're talking about a significant cost savings per member per year in our program. And in this example from which was actually a combination of a couple of our clients, it was $5,400 for those with chronic diseases. So significant costs by properly treating people. This is an example of some of the match cohorting that we do, where we look at someone and their twin in a very scientific manner each and every year and measure their costs over time. So what you see on the left is a 36-month program review where someone has to be in for at least 12 months to be part of the program, matched against their cohort. And then on the right, you see another deeper dive for another client that gets into chronic condition management and the PMPY or PMPM in this case comparisons against those with chronic disease. So these are examples of what we do. And then the managing the human factor, as Larry likes to say, we can look at a host of things. We can measure workers' comp. We can measure errors. We can measure defects. We can measure, in this case, preventable accidents. And what you see on the left is sort of people that are in our program, again, against their cohort over time and what's happening to preventable accidents. And this is 96 months of being in care. So one of our oldest clients, and on the right you see another transportation client of ours over 5 years. So these are the types of things that we can do, and we do for our clients to show that helping people manage their sleep properly can provide savings. So with that, I think I will let you.
Yeah.
You could just close?
Yeah, absolutely. Y'all could go to slide 22 real quick, and then I'll leave you with a summary on 21. So here's a question that I would guess every benefits person has been thinking right now. How do you integrate with the health plan? We contract directly with the employer, so we're a client-specific provider, contracting directly with you, Rutherford County. The TPA, the claim would be managed just like you would manage a claim today. There are a couple of advantages, though. Since we're managing full episode of care and it's a bundled value payment, you've typically got 2 CPT codes. So we're set up, we integrate, filed once a year because it ends annual payments. So once we're integrated and set up, and we work with most of the BUCAs nationally, so we've been through integration process with most companies, if not all, and it's a pretty clean process now. But that's how that works. Entire episode of care and bundled payment. Those are different terms. So bundled payment, a financial bundled payment for us aligns with the way we treat patients. So I think the full episode of care is the thing to focus on there, and with actual health care delivery. Here's some key points. Initial consultation with the physician, there's no charge. So that whole pathway I showed earlier, there is no cost incurred to the patient or to the organization until they say, Larry, you've been tested, here's what we see. We're diagnosing sleep apnea, here's what the process looks like, here's what the structure looks like as a plan member. Would you like to opt in and be treated through this healthcare provider? Yep, I sure would. Filed as a medical claim. There's no PMPM up front for all members. There's no processing fee. So we absorb some of that risk, but it's really not risk for us, because when we start to identify folks, we're going to get to the ones that really need help. If there are any questions on this, let me know. And then we typically contract out 3 months. We're not building in escalations or increases in price. So our goal is, much like the way we treat patients, to take some of that variability out and create a predictable cost scenario where you say, when John gets treated in year 1, here's what it's going to cost us. And here are the outcomes that Larry and John and Knox Health are going to come back and show us. Does this topic bring up any questions here?
Yes, there's a question.
Lisa?
So there's no charge up front on that. 36-month flat case rates. So is that saying if Ed is one of those folks that says he needs sleep, then at that we're committing for 36 months of care?
No, it's a great question, and the way I shared it, I could see why you thought that. So let's say Ed is sleep apnea. Year 1, there are obviously more costs incurred because you've got testing equipment set up. That first year cost is a set fee, year 1 to treat Ed. Subsequent years, year 2 and 3, go down, but they are still flat rates annually. So it is not billed at 3 years.
So it's a cost per participant.
Per patient at that point.
That's right, a
Yep.
patient that gets
Yep.
handed off to you. It's
Exactly.
a flat. I'll coordinate with, I'm thinking, we tried so hard to get all of our data into Cigna, but then y'all will be outside or you'll be inside? Information going to Cigna?
We wouldn't be
Third party.
inside their network per se, but we would partner with them on processing claims, managing the wellness. So we are a provider working with them. It's just not that traditional part of the carrier network or the plan they would have because of the way we contract. Other than our relationship directly with Rutherford, it's going to, go ahead, John.
Was your question related to the data? So, all right,
Claims,
so
yeah.
your Cigna aggregates data for you.
You come back to the microphone.
Forgive me, I'm not used to this. We understand that occurs. We do specific aggregation of your data for you around sleep. And it's a deeper dive into those folks that are treated like I had mentioned. So typically how it works is we will get data feeds and we will aggregate that data. It's now part of our network. We actually acquired the company that did our data analytics for us in the last year. And they provided from ongoing feeds, whatever it may be, medical, pharma, if we get an accident data or other data, and then we aggregate it because we look specifically at sleep. It complements what's done by the carriers, certainly.
So you said you're a provider, so you're no different from Murfreesboro Medical Clinic. They're a provider.
Yes.
You're a provider.
Yes.
Right? I mean, so.
Yes. And we've got, it's not necessarily germane to this because you all are, contained in the county, but we've got a network of board-certified sleep physicians that practice telehealth for us across the country. And then we've also got a network of respiratory therapists to provide virtual training and education for us across the country.
But that is within the flat fee.
It is. And part of it is that in true value-based care design, we don't want to create abrasion with the patient. Someone that joins that has issue with therapy because their mask doesn't fit properly. Traditionally, that would be another claim, another visit to the DME, another doctor. We will exchange that mask. First, you do the proper fitting up front, or someone starts therapy and they lose a significant amount of weight. We provide these things to keep people in care. It's not necessarily about the cheapest item. That's why we believe that value is based on what the patient believes it is.
And my last question, because it's kind of with this, it seems like with Cigna and all the wellness things that we have kind of all coordinate, how will this coordinate with the rest of our programs?
We love those conversations. We love that coordination. We've got clients where we coordinate not only with their carrier, their plan, their administrator, but across the gamut of well-being and wellness providers that they have. Larry had mentioned your on-site strategy. It's a huge win because these are folks that are frontline. I think it was close to 900 folks that you all saw last month that, if they have an issue, they have someone to turn to, and that would be us. We coordinate data as approved by the patient, back to and with. We can do it with disease management programs, diabetes management, hypertension, any heart programs that you all have. We do that typically with a lot of the large players across the country. That answer it?
Jeff?
The program works supposedly with people who work really odd schedules, a lot of overtime, and have issues getting to sleep in an 8-hour time frame to go back to work after working double shifts. And EMTs, firefighters, sheriff's deputies that are working uncountable numbers of hours, and it's maybe hard for them to sleep during the nighttime because of odd schedules. How does that work for those guys?
It's a big reason, as I had mentioned earlier, about how we expanded our program. A lot of the feedback that we got is, someone worked a third shift. And in some cases, they're working a second job on that third shift. So it's really tough. So Larry had mentioned our behavioral sleep medicine physician or psychologist that we have on staff. It's really working with the individual to get whatever, to maximize and optimize your sleep. If you only have a 6-hour window, it's making sure that you prioritize that 6-hour window for sleep and making sure that that window is as effective as possible, because we can't stop the fact that no one can, that you're in a situation where you're working long hours and odd hours, and some days are great, some days aren't so great. So that's really the personal aspect of what we do, where there is that one-to-one, we know we're there and we can work with someone. It's what's called a circadian schedule, right? That we're working with them specifically on how do you maximize what you do have, because it happens, it's reality.
Quick thought on that from personal experience. I mentioned duration time.
Microphone. Microphone. That's all right.
Podium. So shift work inherently outside of circadian rhythm is going to have a timing issue. Number one, they don't know when they may head out. If we can help them control the quality of that 4 or 5 hours, and when they do get to sleep and prepare, it may not be ideal on duration, but I know for me, I can get less sleep in a given situation because I'm controlling the quality. So that's a piece, the duration, time, and quality. We have several levers to pull, and shift work can cause that timing issue, but managing the other, it helps people get through. So, yeah. Yeah, you want to just share?
No. Just to add on to that, as Larry had mentioned, right, you only have so much time to sleep. The other reality is that people that do have enough time to sleep, are they getting the quality sleep? So you might have 8 hours to sleep, but is that sleep really quality sleep? So that's really the sort of personal intervention that we work toward with our patients.
Would you work with me, allowing me and you to convince my wife that an hour-and-a-half nap in the afternoon's okay?
We'll do our best. How about if I sick our chief medical officer on it? We try and stay out of those personal matters as best possible. But we can tell you that naps are good.
Naps are great.
Naps are good, yeah, especially when you're not getting the necessary hours of sleep at night, for sure.
Mary?
I've got a question, and really it's a thought for us as the committee to think about, not necessarily for these two gentlemen, but I'm curious, and Paul's probably not able to speak to it today, but I would like to know how the number and how many people that our Cigna has this problem that is covered, and it doesn't have to be broke apart of who's using and who's not using. I would be curious to see how many folks have the sleep apnea that's been diagnosed, and because if it's everybody counts But if it's a few of 6,000 plus lives, then is it feasible? So that's the one thing, and I can attest to all of this because I myself personally have had sleep apnea and treated for a little over 10 years. So I get it, but is it one of the bigger problems that our county employees have that maybe we need to put our money into something else that is a bigger problem for our employees? You know, like I know hypertension and all that goes along with sleep apnea, but there are other things that don't, and if the sleep apnea is a small portion and there's something larger that we could take our money and time and focus on and really, you know, bring together and try to do this type of service for our people, if it's only going to help, and I can't say a few because a few is just a few, but I know there might probably, but I just wonder if there's a way to get numbers.
I'm sure you all can get claims data and polls. I will tell you what it's going to show. It's going to show that on average 2 or 3% have had a claim within your population for sleep disorder, in particular sleep apnea. And I can tell you within your population where you are, that number is probably, how many employees do you have in total? Over 6,000? That number is close to 1,200 for sleep apnea alone. And the reality is that you probably have less than 100 that are treated. And I know you said this is a community thing, but I will tell you, you're not giving anyone a fighting chance to fight anything that you perceive to be a bigger issue if you're not tackling their sleep. And I will posit this to you. Someone said this to me a couple weeks ago, actually from Cigna. How do you manage the whole person in healthcare if you're ignoring a third of someone's life? That's the importance of sleep to us. Yes, we're very passionate about it, but that's not a sales pitch. That's the reality. I've benefited from apnea therapy for the last 4 years myself, and I know what it's done to hypertension. It's taken it away from me. I know that it's helped me lose weight, so I know the personal impact of it for me. It's a lot bigger than you think, but in the claims data, you're going to see that only 2 to 3% has ever been diagnosed because it's so drastically underdiagnosed. And I would be willing to bet that if you were to pull claims on obesity, the obesity rates from your claims are a lot lower than your actual obesity rates as well.
So this presentation was for information for this committee to think about and look for different ways that we can provide opportunities for better health for our employees. How would that work? Would this, the payment, would it go through Cigna or would it be billed to the county directly? Tell us how you do that, because I see all the organizations you're currently doing business with, Delta, Coke, et cetera, they're all private sector, us being governmental.
We do have, we do serve
Public
some
sector.
counties, yes.
Okay.
And the way it typically
Talk
works,
right,
yes, the way it typically works is, thank you for continuing to do that. The way it works is we would be contracted with you, your claims administrator would administer the claims. We would work to make sure that it runs through their system properly, but the claims would run through the claims wire against your budget.
Well, since we just renewed our budget starting July 1, and this was not anticipated at that point in time, is that something, Lisa, that we would look at for next year? Does the committee discuss it? Do we make a recommendation to the full commission?
And Ed probably can answer this better than I, because what I'm hearing in my mind, it's who directs, again, it's you're saying you're no different from any other provider. So I choose, if I happen to live with somebody who cannot sleep, and I say you need to go get a test, and there are sleep study places here, is it a choice then as that person, I want to go here, or are we offering as a change to our plan that this is a place that you could go make part of our plan document, that is an okay thing. I don't know who picks it, because I'm thinking, okay, so if the person goes to the sleep clinic and then they're under a doctor, their primary care person is saying go there, I don't know at what point that somebody says, have you thought about this group?
Right.
And if you go to this group, we will treat them as if you were all like a primary care, and because you're going, it's what I understood, that you're taking that person through all the issues that they may come to the table, not just sleep. Did I miss that? Or are we just talking about sleep?
Yeah, but what we're actually providing for and billing for through claims is for treating sleep disorders. But as is the nature with what we do, these are physicians that are having whole person conversations with people. And as part of gathering medical intake, we can coordinate care with those that are providing other care for them, primary care in particular. We have a person that has a sleep issue that's a diabetic. And our doctors are saying, okay, make sure that we're coordinating with the primary care physician to ensure that this person's diabetes is controlled.
Okay, so then you're like a specialized something. So if I have a broke leg or something and I'm going for therapy, I'm going to TOA as opposed to somebody else. I'd be going, if I'm looking for sleep, I might go to y'all instead of this other one. Is that it?
Yes, and we've done it in many different ways with different contracts. Most of the time we're a preferred provider so that we limit abrasion that exists. If someone has a sleep doctor that's been treating them and they're fine with that care for years, then it is what it is.
I guess I would to figure out how does it coordinate with our plan. And
right, and that's what I'm trying to digest here is you're, from what I understand, you're not in our present network with Cigna.
That is correct.
And if you're not in our present network, how do we run our claims through? How do we get the data in our CAP reports to where it's integrated into the Cigna information, where and how the claim's going to be processed through Cigna, our deductibles, our out-of-pockets, and all of that stuff?
We do all of that with Cigna on your behalf, where we actually integrate in a way that they can run the claims through the wire that are compliant with ERISA plans and compliant with deductibles and out-of-pockets and all of those good things. We do collect patient cost share. We've done this with the BUCAs, so we've done it with all of the larger payers in the marketplace. It's something that we do during implementation where we get into the specifics of what your needs are. For instance, do you want this to be a preferred provider? Do you want steerage that exists in there? However you'd like to do it, that's how we implement it. But we do run through the claims wire just as any other claim would.
We would have to have a separate contract, is what you're saying, than what we have with Cigna in-network.
Yes, we would be for Cigna, and we're pointing to Cigna. I guess these are Cigna people in the back that where we're integrated as a CSP. We're a client-specific provider that we integrate with you directly and work with them on it. And we've had plenty of conversations with the good folks at Cigna, up to include some very recent conversation about it. So yes, we're very used to doing that.
All right, we got Lisa, Amber, and Mary.
Okay, so we would have been planning our rates, our rate structure based on all the data that comes in and estimating cost and all that. So I think that you would need to rerun all those things, because I'm sure if y'all have been around, they know about how much claims cost this will ultimately cost us. And is our existing rate structure able to cover it?
Yes, the answer is yes. We work within your plan design.
For 22 are already set.
Yep.
based on our budget.
Yeah, and the reality is that this is deferring existing budget to a large extent, because these are people that are seeking care at times as well.
Amber, no question, you're good. Mary?
Okay, so, one, Paul, I would like some numbers on just, how many are being diagnosed with the sleep apnea out of our covered lives. But the main thing, it sounds as if we need to get Cigna with these gentlemen to see if it's even viable for them to become a PPO provider on our Cigna list. Then, if any of our doctors, whether they're at MedPoint, my personal doctor, somebody at Murfreesboro Medical Clinic, could send, if they're on our list, could send them to these gentlemen's provider, everything sleep related, and that, because they would be a PPO provider through Cigna, it would go through everything. So I really think what needs to be looked at, my personal opinion, is what would it look like if Cigna courted these gentlemen and got them to become a preferred provider for our employees. And then it's just another tool in the toolbox. There's somebody else you can go to that maybe a different provider is like, oh wow, this is new, this is the new coming stuff, we're going here now, instead of making the 2 or 3 trips to here, to here, to here, and get it done. I see this helping us more, if possible, as to being a preferred provider through the Cigna network instead of something totally out here that would affect the rates and changing the model plan. I really think like he said, they're a provider, and it's no different than a new doctor coming into town and Cigna having to go and court them to say, hey, would you like to be a preferred provider? Here we are, or if not.
Is it similar? Is it similar to the program that we did for the pre-diabetics?
The OMADA program?
The OMADA program.
Okay.
Yes.
Yeah. There are some similarities, yes.
Just in response to Mayor Ketron and some of the others, we implement mid-year outside of the annual enrollment as much as we do following that cycle because of the way we're structured. So going off cycle to the benefit plan is not unusual for us. And that's because we're deferring costs within the health plan, and it's not up front. So your risk, people will say, well, Larry, you're telling me I'm going to find 10% of people with sleep apnea? This could be expensive. Well, we've all agreed that we're doing it for the right reason. Yeah, so going off cycle is not unusual for us. And every question y'all have asked today are typical. Benchmarking, what's our cost now, what's our prevalence now? And that's what we typically do up front. So these aren't unusual things. Yeah, but it's off cycle sometimes gives a shot in the arm 6 months in. Yeah.
I got a signal from Paul. Paul, you'd like to come up and make a comment from Cigna?
Uh-oh, he's going to take the podium. Yeah.
So, Mary, you asked about the similarities, or no, you asked about the similarities with this and OMADA. Well, the difference is that we have a preferred relationship with OMADA. That's what allowed you to add the OMADA plan to our existing plan without having to do anything else, and just add it as another provider in our network. The difference here is that this would be a contract that Rutherford County has directly with a sleep charge, okay? Typically in our situation, municipalities, that requires you to go to bid, put it out there for sleep care. You pick the best vendor, you pick them, then they contract with you. They hand me a contract that you both have signed. We administer it as a client-specific network, okay? Because they're not in our network, but you as the self-funded client tells us, pay claims from them, and we're happy to do that. okay? But that's an outside the current existing Cigna relationship. But we do it all the time. What's that? You have not had that before. Now, well, I'll take that back. Your on-site clinic does that exact thing. Okay? So your on-site clinic, we developed a client-specific network for them so that they could send claims through us and to be paid at 100%, different than other providers, right? So you had to go to market, bid for them, they win, they sign an agreement with you, they give that agreement to us, and we administer it.
Use your mic. Use your mic. Button at the end, at the bottom. There you go.
Are these two doctors here local?
No, they're not. Dr. Barrett is out of Jacksonville. He was in private practice and then served the Navy until recently. And Dr. Ong, who's our behavioral sleep medicine, he's a PhD. He's out of Dallas, Texas.
Who is local?
We have doctors in Tennessee. I'd have to get you who the doctor in Tennessee is for us, but yes.
Is there an office here in Murfreesboro?
Say again?
Is there an office?
No, I think that's important to understand, and maybe we weren't clear on that. Everything that we do is via telehealth. It's all virtual throughout the country. So the sitting in your car for us to come get you and all that, we take all of that away because we do it all virtually. There is no going to a sleep lab. We're sending the devices to you at home.
So you've eliminated I think I heard you in your presentation talking about, you go to your primary care physician, primary care sends you to a sleep clinic, then you go and you sleep, and then you're like 6 or 7 stops before you ever get an opportunity to quit snoring, right?
That is correct.
I mean, my wife's been trying to get me to go because she says, roll over, you're snoring again, so I probably need to go. And I may be one of those, Mary, that is not in those statistics.
And that's the thing about claims, is you only have what people have claimed or submitted.
Yeah. Okay. Any further discussion? Gentlemen?
Not from us. Thank you very much.
Okay, thank you all for your presentation today.
Yeah, thanks for the questions, too.
Yeah, that's something I think that, as there are opportunities out there for this committee to make decisions upon, if it can help us, then that's something that we may want to bring up and discuss. Think about it, the presentation, if it's something we want to discuss again at our next meeting, and we still have time to move forward. If it's worth, or do we put it out to bid, for 3 different companies or whoever is willing to bid, and we go from there, and then we could coordinate back with Cigna if that's something that we feel that our employees need, and can help reduce our payments because it's identified some of these health exposures through this sleep therapy. Again, I might need to check that out myself based on my wife. I need a nap, Jeff, sometimes at the pace that we run, right?
I kind of like, if you take Commissioner Phillips' idea and you take Mary's idea, to help the employees, maybe we should just be able to take a nap, all employees take a nap in the afternoon, and we all might be a lot healthier.
I think the insurance committee should go to Iceland to their home office and do a road trip and check that out and see how it can arrange that. And, they just sleep a lot in Iceland, right? It's so cold and dark. Yeah. Okay, members, thank you for the presentation. Well, the last thing we have before us is the county employee vacancy appointment. So last time we had 2 members, actually there were 3. One didn't show, that had filled out the form and requested to come on to this board because we do have a vacancy. And we felt Mr. Elam wasn't here, but we went back and checked. Really, we referred it to the steering committee because the steering committee on the county commission does most of the appointments of all boards with volunteers, et cetera. Well, come to find out, this board decides their replacement. So we re-referred it from the steering committee back to this committee, so you're going to get to vote today. And you may have just kind of cleared your mind of those candidates who've expressed an opportunity to come onto this board and serve with you. So today we have, and if you'd like to bring you back up, I'd like to get, we have Michael Curtis. He's with our Office of IT, our IT department. We have Mr. Brian Gaither with EMS, and then Joshua Sanders with Fire and Rescue. Mr. Sanders is again not here today, but if you would like, because you're going to vote, before you do that, would you like to hear from them again? You're going to, so why don't you just come up? We'll start out with Mike. Mike, if you come up and just reintroduce yourself to the committee, because they're going to be voting on you. And let me say before, as you're making your way up here, Mike, these are county employees who will be, one of these that you select today will be joining this committee. And I just want to, they're both good quality candidates. They're good long-term employees and have the interest of wanting to serve and give their time to help make things better for all of our employees and our community. So Mike, if you will, reintroduce yourself, tell the group a little bit about yourself and why you desire to come onto this board.
Thank you, Mr. Mayor, members of the committee. Appreciate the opportunity to come and speak in front of you again today. Like the mayor said, my name is Mike Curtis. I am the GIS manager for Rutherford County, and I work in the IT department. I have worked in several agencies through my 31-year history in Rutherford County, and in that time period, I have worked with a lot of different departments and have gotten to know a lot of different people that are members of the general fund employee pool. We work with them currently through the GIS department on a regular basis, so I have lots of contact with all levels of the county general fund, and feel like I would make a great representative with my knowledge of the county and the people that work within it to be on this committee. I also have a lot of experience with working with numbers and statistics, and that's about it. So thank you for your consideration. Okay. Thank you, Mr. Mayor.
Thank you, Mike. Okay, Mr. Gaither, if you'd like to come up and introduce yourself, and you've done this before, so everything's good.
My name is Brian Gaither. I work for the ambulance service. Been there for 25 years, started in 1996, paramedic on the ambulance. In 2007, was promoted to a supervisory role. Within that role, I have seen, the benefit side of it from an employee and a supervisor helping the employees with the enrollment. Currently, the benefits package is crucial for county employees for retention, recruitment. You hear that used a lot recently. I have a medical background, so the medical terminology that may come in front of this committee, occasionally I'm making help with that side of it. In 2018, we started a division off of the EMS agency, non-emergency division, which was completely different from the 911 side, so I had to learn a lot about billing and coding and what was covered and what wasn't covered, so got further into insurance than I had ever before, and I think with the medical background and maybe some of that billing side background, I think I could be a benefit to this committee. Thank you.
Okay. Thank you. All right, members, you're going to be voting for one of three, so write these names down. And so the first one was Mr. Curtis. So it'll be, when Ms. Corbin calls your name, you'll say Curtis, Gaither, or Sanders. Now, Mr. Sanders is with our Rutherford County Fire and Rescue. You haven't heard him, you may know him, but you still may want to vote for him. That's your choice. So when Ms. Corbin calls your name, we'll record the vote, and you say either Curtis, Gaither, or Sanders. Okay? Is everyone ready? Understand? All right, Ms. Corbin, call the roll.
Dr. Andrea Anthony. Yes, who would you like to vote for?
Yeah. Either Curtis, Gaither, or Sanders. Okay, pass. We'll come back to you. All right.
So we've got Amber Brown.
Gaither.
Thank you. Holly Deering. Mary Hickerson.
Curtis.
Jeff Phillips. Pass. Shantae Sherrill.
Curtis.
Eric Tuto Benning. Dr. Andrea Anthony. Curtis. Sir, we are 3 and 3, so you will make the final, unless Mr. Commissioner Phillips would like to do that.
I'm sorry. All right. Mr.
Jeff Phillips. Thank you, sir. That has Gaither 4-3.
4-3. Mr. Gaither, we say congratulations. Mr. Curtis, thank you for applying. We certainly appreciate that. And we'll say the same to Mr. Sanders as well. So, Mr. Gaither, you'll join us at the next meeting. We thank you. Anything else to come before us today? All right. I'm sorry? No? If I will entertain that motion to adjourn, and Commissioner Phillips, he just seconded. We're adjourned.